thank you for holding this important hearing today about the obstacles to expanding health in rural America. And thank you to all of our witnesses. Thank you for the work that you do. Thank you for taking the time to be with us and to share your perspective. My home state of Missouri is home to a very large number of rural communities. I grew up in a rural community. And I know when I talk to my constituents back at home in these regions, one of their top concerns, if not their number one concern, is access to quality, affordable health care. And that is all the more urgent because Missouri's population is rapidly aging. We've got a lot of seniors in the state of Missouri, and a lot of them live in rural areas. So the topic of today's hearing is very, very important for my state. Mr. Dombey, let me just start with you, if I could. In your testimony, your written testimony, you discussed the innovative uses of telehealth and telehome care in particular as a way to bring home health care to patient populations in communities like the one where I grew up. I'm aware of the infrastructure barriers to telehealth expansion, including inadequate access to quality broadband that, of course, places a huge restriction on healthcare providers in rural regions. Despite these barriers, Congress, I know, has taken some incremental steps to expand telehealth and telemonitoring capabilities, but I think that we can probably do more. And I just want to ask you, what lessons have we learned so far in your judgment in demonstrating the cost effectiveness of services like telehealth, telehome care, and what are the most promising areas, would you say, where we can utilize those services more strategically?
The number one gain we've seen in the use of telehealth, or we call it telehome care, a term which someday might be adopted, but in terms of telehealth, is remote monitoring by non-physicians as a way of keeping people from going back into the hospital to avoid readmissions of the individual. It's important to have boots on the ground, people to see face-to-face the patients, but that 24/7 monitoring of a number of patient categories has proven a high reduction in readmissions. One readmission avoided to a hospital saves tens of thousands of dollars with very little cost attendant to it. We've actually been working on a proposal to advance to the Centers for Medicare and Medicaid Innovations to create a risk-based telehealth program where the provider of the telehealth services would put tremendous skin in the game so that they would only be paid, or they would only be paid fully, if they demonstrate a cost savings to the Medicare program. So we think that opportunity exists today out there, and it does not always need physicians. As I mentioned, these are non-physician-based remote monitoring services.
That's very helpful, thank you. Do you have any recommendations for home health agencies that are looking to set up new programs?
Well, come in with some capital because the reimbursement systems are not yet up to date where it needs to be. And that's why our proposal would have a risk-based approach to it because, frankly, when we've been working on some of these issues for over 10 years, we figure we have to change the dynamic, and that's what a risk-based proposal would be about.
Very good, thank you. Ms. Howard, let me ask you on this topic of access to telehealth services. I wonder if you could speak to your experience serving on the ground with rural communities. Older adults, we know, experience the highest rates of adverse drug events resulting in emergency visits and are several times more likely than younger persons to have an adverse drug event that requires emergency hospital admissions. They're also more susceptible to chronic pain, we know, and many of them are prescribed opioids to control and manage the pain. Have you been able to leverage your program's telemonitoring technologies to identify changes in patients using opioids?
That's not an area that we've currently been working on. But however, having the telemonitoring in the home, of course, many of our patients are on 25 or more medications, and many of them, are on opioids. So having that nurse checking in every day would help to be able to identify certain challenges or things that we need to follow up on. The other thing, too, that I will add about the telemonitoring is it really allows us to make those home visits on a demonstrated need, meaning we see changes in the patient's blood pressure or based on different questions that they answer. So when we talk about workforce shortages, this allows us to make those visits knowing when they need that visit instead of anticipating when they may need a home visit.
That's very helpful. Let me ask you this, my last question. Beyond expanding access to broadband, which is critically important, I think, for so many reasons, and telehealth is at the top of that list, and providing more reimbursement coverage for telehealth services, do you have any insights from your experience for us about what Congress might do to make home health care programs better, more available to more Americans?
So one of those challenges that we have are, our patients that we see are in their acute state of their disease. So maybe they've had a heart failure, readmission to the hospital, they're discharged home with our service, and we are using our telemonitoring equipment during that fragile time to clue us in as to any changes that might happen that would send them back to the hospital. So we're able to take action based on those. Currently, we can only see that patient for a short period of time. Eventually, we need to work to discharge. So that patient returns to that chronic health state of their heart failure, for example, and we need to remove our telemonitoring equipment. We remove the nurse, we remove the therapist or the home health aide, and that patient is now on their own. And so what usually happens is after a period of time, eventually that patient may run into trouble again. And in order to access our care again, they end up going to the ER, going to the hospital, and then the referral back out to home care again. And here we go out to do what we do best, to keep them out, only again for a short period of time, and we just are in that cycle. We have been able to work with some of our Medicare Advantage plans where we do telemonitor patients after their discharge from their skilled home care benefit. So we telemonitor those patients for extended periods of time, sometimes make a home visit, but what we're able to do is identify those changes in their health status. For a heart failure patient, it could be an increase in a weight, or they're reporting through their telemonitoring system that they're short of breath. Our nurse goes out and assesses the situation, is in contact with the physician, and many times we're able to make medication changes at that point in the home, readmit them to home care service, and then care for them again under that acute state. So we've bypassed that ER and that hospitalization visit, which would have normally brought them back to us. So we've had great success with that.
Very good. Thank you. Thank you for all that you do. Thank you, Madam Chair.